The following webinar was recorded as part of the original implementation of IWISH and has been made available for informational purposes only. Some portions of the original recording have been cut to ensure participants' privacy. References to the Lewin Group, Implementation Team, Site Liaisons, PHL, Google Drive, and some forms are not applicable to the demonstration extension effective October 1st, 2020. Terms and conditions of grantee's cooperative agreement supersede any information presented here. Please see the IWISH Operations Manual for the most up-to-date implementation information.
Good afternoon. So I'm glad we got the technical difficulties taken care of and that we're with you this afternoon. And I'm a clinical social worker with 40-plus years of experience and have worked in a variety of inpatient and outpatient settings and have done extensive training and consultation in housing sites. And we're going to be talking with you today about working with residents with serious mental health challenges. And to set the stage for today's webinar, I want to share the following case example, which highlights the creativity and collaboration needed to work effectively with residents who have these serious challenges. So there was an older woman, Mary, with an early dementing process in one of the buildings I consulted with, and she adamantly insisted she was being slowly poisoned by gas being pumped into her apartment.
I can just see some of you nodding your head.
And after verifying that there were no leaks or indications of any gas problem, we tried reassurance, which of course did not work. And other residents with whom she interacted began to be concerned that they too could be experiencing a gas leak. Because Mary had a good relationship with the head of maintenance, we tried an intervention that I have seen work in similar cases. It does not always work, and one of the key things we'll be talking about is something doesn't work, then you go to Plan B, Plan C, or Plan D. But in this case, what we did, we had several maintenance men don hazard-type gear. They went into her apartment with a collection of hoses, etc., and allegedly made adjustments and reassured her through showing her a gauge that indicated the air quality in her apartment was good. The gauge reading was indeed accurate, but the bogus adjustments were all about reassuring her that her concern was being taken seriously and being addressed. She accepted this, and the issue was resolved, and Mary continued living in this housing setting for several more years before her dementia made independent living impossible.
So we're going to, next slide, please. So we're going to talk about the staff and the roles of the staff. And there are a couple things that, a couple roles that may not even be listed here. You may also work with a fitness manager or an activities person. It is possible that everybody on this list will be engaged in supporting residents with mental illness at one time or another. I'm going to remind everybody that approximately a quarter of all adults experience a mental illness during their lives. And we tend to forget that everyone on this call is in that 25%. So as Marcia and I are talking, be thinking about how you would want to be treated if you suffered from one of these illnesses. Next slide, please. So we all know that supporting residents who are to the left or the right of the bell curve is like putting together a puzzle. And sometimes the residents visit the resident service coordinator or the resident wellness director several times a day. And sometimes the resident will only speak to the executive director because they insist on, quote unquote, going straight to the top. And sometimes the only person that the resident wants to communicate with is the maintenance staff. And it goes the other way too. we each have strengths and preferences with certain types of behaviors. And we understand that IWISH has its own rules around confidentiality and that management has its own policies around sharing information. However, we're including in this section for several reasons, because sometimes a resident's behavior impacts a community and it really needs to be handled by more staff than just the IWISH staff, the resident wellness director or nurse. And also, as I mentioned, the resident may feel more comfortable sharing or working with a staff or community member than with the IWISH staff, or the staff may need support with particular residents.
And we need to recognize our own comfort and preference and acknowledge that we don't work as effectively with every type of resident. So my least favorite type of mental health challenge that we're going to be discussing at length in a little while is borderline personality disorder. So if I have a resident that I really am having difficulty supporting, I might ask another staff member to step in, especially if there's evidence that she or he would be more effective than I. Next slide, please.
So sometimes outside resources also need to be brought in to support the resident's continued residency. And I think it's important to mention here that supporting a resident who's struggling with a mental illness requires long-term management, as Marcia mentioned. It's not a one-and-done scenario. So even when the behaviors exhibited are disruptive or troublesome for management or other residents, it's not an automatic lease termination. It is, and management doesn't decide that anyway. It sort of goes to a court of law. In Massachusetts, and I don't know about the state that you're in, the courts are resident friendly. And more often than not, the judge will tell the management company to work it out and maintain that resident's tenancy. So that's why this stuff is so important, because it's not a, I'm not dealing with this situation. It's a, we have to deal with this in the long term. So who are the players? Not only do all housing staff have the opportunity to support residents who struggle with mental illness, but sometimes we need to look outside the housing site to connect the resident or ourselves with mental health professionals. Sometimes it's family, and we're going to talk about that, about family dynamics in a few minutes. And sometimes it's a primary care physician that can make a referral if the resident isn't already plugged in. Sometimes it's the police who respond to 911 calls from people, from other residents, or from the residents themselves. We had a situation where it was a confused resident and he heard a noise and he called 911 and it really wasn't, it was nothing, but the police did respond. And sometimes it's the emergency response folks or hospital or mental health clinic professionals. As one of the attachments to the guide that we talked about, there's a form that really should be filled out ahead of when you need these folks to come and react. That form is on the jche.org/guide that we talked about last time. And one of the attachments is this form. And we recommend that if you don't already have relationships with these folks, that you make contact as soon as possible and invite them to the site and ask them to make a presentation or foster a conversation with residents about mental health and about mental illness, and that your community would support them the same way if they had an incident. Next slide, please. So we recommend using a resident at-risk team that's made up of a variety of members of the housing and or management staff. And credit where credit is due, a friend of mine, Sarah Green-Baswani, who is a resident service coordinator, created this at-risk title because the former name of the committee was the Troubled Residents Meeting. So we switched it around a little bit. So The meeting got, so obviously these are the folks who are residents at risk. Either they're exhibiting the behavior that is troublesome either to other residents themselves or staff. They're at risk at violating their lease. They may have already violated their lease. And this is for residents who do give permission to the IWISH staff to discuss their behavior with other staff or community members. They do have to give permission if you are going outside of the staff. Okay, next slide. So the meeting guidelines are that every staff person who attends brings his or her area of expertise. And that might be that a maintenance person speaks the same language or comes from the same culture, or some other staff member speaks the same language or comes from the same culture, and the resident is more comfortable with that person, as I mentioned. So one person directs the meeting, and another person takes the notes. And then these notes, as it says, are distributed, and the goal of this is so that everybody's on the same page. The staff agrees on a unified approach to a particular resident issue, taking into consideration the IWISH confidentiality rules and the management policies and the permission. And each staff member comes up with their own ideas, and everybody discusses it. And it makes for a balanced approach to problem solving, and it results in a common approach to the problem. Okay, next slide. So as I said, the notes are held confidentially, and so that's why we suggest having a password attached to the email. So it's not a HIPAA violation, and I want to make sure I say that, because the staff is not sharing a diagnosis or Social Security numbers or so forth, and you're only conferring on management's response to a behavior.
And it's a shared approach, and it potentially minimizes splitting, which is a kind of behavior particularly seen in personality disorders. And we're going to discuss splitting and ways of recognizing when that's going on and how to deal with it in detail in our final webinar, number 3. Next slide, please.
Okay, so what we suggest is that a plan is made for the future action, or for the action that the staff is going to take. One staff person is assigned to follow up with the at-risk resident unless you feel, or the staff person who's making the contact feels safer or better about 2 people going in to, if the resident, for example, does splitting, that resident is going to say 2 different things to 2 different people, and you may need both to hear what the resident says. And then the new at-risk resident is presented and a plan's made for the intervention. So this is a sort of red light, yellow light, green light method of addressing the challenges, and this group of residents are the yellows and potentially the reds. Okay, next slide. So, so once the meeting is over and everybody has their sort of marching orders, the staff visits the resident and follows up with a letter as appropriate. So if it's a hoarding situation or if it's a noise situation, a follow-up letter should be sent. And then you may want to make regular visits specifically with a hoarding, and Marcia will talk briefly about that a little bit later. But I understand that you have hoarding training, so we are not going into all of the details about hoarding. So they may make regular visits, and that, again, there may be a good cop, bad cop kind of thing with residents that you might want it, or you may need to try. So if a problem is resolved, for example, last webinar we did a role play about somebody's television being too loud for another resident. if that person gets headphones and is not keeping their volume up so loud that it's disturbing the other resident, so then that problem is resolved and the at-risk visits cease. But obviously hoarding would probably continue. And then progress notes are made at the monthly meetings. So, for example, the IWISH staff had been informed by a resident of her bipolar diagnosis. You have a resident with long-term mental illness whose psychiatrist retires, and she's run out of medication and begins to have a manic behavior in the common areas. So multiple residents have complained about her behavior. That would be something where if you plug her into the system and she gets medication and her behavior goes back to baseline, then you wouldn't have to continue those visits. Okay, next slide. And sometimes there are really difficult situations, and we've certainly had those. Very, very long story short, as it happened, we had a resident who had no family involved, and it took about 16 members of the staff and the community and the hospital to address her issues, and staff became like a family to her. And of course, sometimes you really just need all hands on deck to try to support this resident. Okay.
Next slide. So what's going on here? When you encounter a resident and you're concerned about it, what's going on? In webinar 1, we discussed the importance and the criteria for assessment and what to be observing in all your interactions with a resident. So for example, if you see Mrs. Wang in the mailroom and you note she's disheveled and distraught, you have a basis for knowing this is different. So the first steps, you're listening to Mrs. Wang to hear what her concerns are. Perhaps she just learned her favorite sister in China died and she can't afford to attend the funeral. Or she might be exhibiting mental status changes due to an acute infection, common with urinary tract infections, UTIs, or upper respiratory infections. When I worked in an inpatient geri psych unit, we had many folks admitted for acute psychiatric reasons who turned out to have an infection that when treated with antibiotics, their psychiatric symptoms resolved. Or Mrs. Wang might have an ongoing psychotic disorder that she did not exhibit in your initial contacts with her. She might report to you that she hasn't slept in several days because of the strange men coming in and out of her apartment. Next slide, please. So Mrs. Wang may be exhibiting delusions. What's causing the delusions? You want to think about delirium, which often includes visual hallucinations like strange men coming in and out of her apartment, or psychosis with or without dementia attached to it. Next slide. Delirium is something that, while we can't medically diagnose it, it is a medical crisis that requires prompt medical attention. So whenever you notice that someone, and this is where that assessment piece is so critical, has an acute or sudden state of mental confusion, particularly if the changes are fluctuating and reversible. They go between lethargy to agitation and back again. That is something that really requires close and prompt medical attention. It's most common in older adults with an underlying dementia. The prevalence is actually 14% in those over age 85, so be particularly concerned about your oldest residents. It's highest in hospitals, post-surgery, or in nursing home or rehab settings. What you might see is things like disorientation to time and place, a decrease in short-term memory and recall, changes in alertness that tends to be worse in the evening, wandering attention, confused or unclear speech, emotional or personality changes, and a new onset of incontinence. The causes can be anything from alcohol and drugs to a chemical disturbance like someone having an electrolyte imbalance, infections like the urinary tract infection or pneumonia, having been in the surgery, been in the hospital or a rehab stay, or poisons. Next slide, please.
So we're going to talk about how to respond to somebody with delirium. And, you know, I say you're going to know if somebody is delirious because their behavior is going to be sort of what you might characterize as wacky for them. So the very first thing to do is stay calm because they're not calm and they need you to stay calm. And keep the environment as relaxed and peaceful as possible while seeking medical help. So if it's in a common area and you can get the person to come into a quiet office or a quiet room, that's the first step. The second thing is minimize the number of people involved. Clearly, if there are other people around, they're going to know something is wrong and they're going to, you know, like we all do, rubbernecking. So make sure that you really have as few people involved as possible. The third thing is to speak really slowly and clearly. Don't rush and don't shout at the person. Repeat questions if needed and allow time for the resident to respond. Next, call the resident by their name and identify yourself every single time. And offer education about the need for medical attention. You really want to get the person on the same page with you that you know that something is happening with them and they need to seek medical attention. Try to understand what they want. I know that might be difficult because they may not be able to clearly express it, but that's what your goal is, just to try to understand what they want. And call 911. If the resident is unsafe or belligerent about getting help, bring in the big guns. Call 911.
Let the EMTs evaluate whether they indeed think it's a delirium and that the person needs to go to the hospital even if they're not agreeing to this. Next slide. So let's talk a little bit about, is it dementia or is it
Marcia
depression?
and Karen?
Yes.
Excuse me 1 second. I hate to interrupt, but before you move forward, we had a question in chat. I didn't want it to get too far before we answered it. The question is, why is the meeting discussion about residents not a HIPAA violation? So you mentioned earlier meeting about the residents with other people. So the question is, how is that not a HIPAA violation?
It's a great question, and what you're discussing is the resident's behavior, and that, in fact, affects the community, it affects other residents, and it affects management, and it needs to be addressed. To my knowledge, it is not, you're not discussing the things that make it a HIPAA violation.
So you're not giving a diagnosis. You're not saying, I know from the evaluation that we've done in the IWISH program that this person has bipolar disorder. You're simply discussing the observable behavior.
All right, thank you.
You're welcome. Shall we move forward?
Yes.
Okay, so dementia or depression. It can be very confusing to differentiate because often depression is present in an early stage dementia. In a major depression, the person is worried about their memory. They will self-describe that my memory is shot, and they tend to have difficulty concentrating. In contrast with dementia, the individual can't recall short-term information, what they had for breakfast. The depressed person is generally oriented ×3, while the person with dementia is not. Language skills are generally not impaired in someone with depression, although they may be withdrawn and they may speak less. With dementia, the person will have difficulty naming objects or not use them properly. The classic example is taking a toothbrush and using that as a comb for their hair. Often the person with major depression will feel his or her memory is worse than it actually is, and they will complain about having a poor memory. In contrast, someone with dementia may try to hide or compensate for their memory impairment by making social conversation or becoming irritable when they're asked about their memory. Next slide.
So in the next group of slides, we're going to talk about Alzheimer's and what it is. I understand that you will have training specifically about Alzheimer's, so I don't go into that much detail in this webinar. What dementia does, what it is, it's a neurocognitive disorder that makes it difficult to remember, to learn, to communicate, and eventually to take care of yourself. And it may also change a person's mood and personality, and we're going to talk a little bit about that. Of course, it's a major risk factor for nursing home placement, and I do a training that's separate from this specifically about Alzheimer's, and that's one of the things that I talk about, that even if staff can support somebody with memory impairment, with Alzheimer's for a few more months or an extra year or two, it's that much longer that person is able to stay out of a nursing home. Okay, next slide. So what is dementia? Dementia is actually a group of symptoms. It's not a disease by itself. You can see here these 4 things are the most common things that people say that dementia describes. You can think of it like blindness, okay? There are many things that, excuse me, cause blindness, such as diabetes or macular degeneration, cataracts, glaucoma, accident or injury, or somebody could be blind from birth. And that doesn't describe, blindness just describes the symptom, or, right, not the disease that caused it. And lots of things can be dementia can be caused by lots of things, like vitamin deficiencies, Marcia mentioned UTIs and other infections, upper respiratory infections, hospital stays, loss of a spouse or other loved one, okay, can cause dementia. Okay, next slide. When the memory changes start to disrupt daily life, that's when somebody with memory loss or even mild cognitive impairment should really get checked out, because it would be best to figure out what is causing the dementia, okay? So some of the other symptoms are problems with planning and problem solving, or difficulty with familiar tasks, as Marcia said, like brushing your hair or your teeth or taking care of your personal care. Even writing a check or driving are some other familiar tasks that people lose as they advance with dementia. Obviously, confusion with time or place. You may see this, a resident may be waiting for the adult day health bus at 8 p.m. instead of 8 a.m., and they're very confused with time or place. And trouble with spatial or visual relationship. You may see this in the dining room when somebody is trying to get those peas on a fork, or you may see it if there's a carpet that is a dark color and you see somebody stop in front of it because they think that it's a hole. So those spatial and visual relationships. Okay, next The other things are problems in words or speaking and in writing. When I say that, if we were on this webinar and you were furiously writing down everything that I said, and I started by saying right? It would be like, oh my God, I've missed something important because you didn't understand what I was saying. And that can be terrifying for somebody. You have to maybe figure out if it's a hearing problem or if it's a brain problem. And then the rest of the things on this page, you can see, these are some of the things that you look out for because they are symptoms of dementia. And I want to just talk for a second about withdrawal from social or recreational activities. The thing that Marcia and I have talked about is change in somebody's personality or a change in the way that they approach you. If somebody has always been an introvert and they're not participating in the building, if somebody moves in and you don't see them come and join in, don't think right away that they're withdrawing from social or recreational activities. You really have to know who the person is and what their personality is to know that they prefer to have tea with one or two people in a small group and, you know, and that's that, and not really join in the larger activity.
And that's partially why it's so important, the detailed evaluation that you do when they join the IWISH program, because that should give you, again, that baseline, the opportunity to find out about who this person is so that you can tune in to when there are changes.
So the last part of, next slide. Yep, next slide, please. The last part that we're going to talk about dementia is changes in mood or personality. These are some of the things that might jump out at you, that the person didn't used to be like this, but they're like this now. And to get to the bottom of it is to really sit down and talk with them and see what's going on for this. I wish we had more time to talk about dementia, but as far as I know, you will be having training on this important topic.
Next slide. So this is a term that I've coined. It's not, you're not going to find it anywhere else. For want of anything better, I call it Dementia Plus. Approximately 40% of people with dementia exhibit depression. And this depression impacts both their functioning and their quality of life. And even somebody with an early or moderate dementia can respond to treatment, which will improve both their functioning and their quality of life. Up to 70% of people with dementia show signs of anxiety, which is not surprising when you think about how terrifying it must be in those early stages when you have some awareness of the skills and capabilities that you're losing. In terms of psychotic symptoms, things like that we're going to discuss in more detail, hallucinations, delusions, or paranoia, these occur in approximately 25% of those with more advanced dementias. And specifically, those with Alzheimer's disease, better than 50% of them demonstrate psychotic symptoms at some point over the course of their illness.
And that has more to do with how the disease is affecting their brains. So it's not like they woke up one morning and said, I think today I'll decide to be psychotic. It's really what's going on physically in their brain.
Next slide. So to make this really real for you, what we hope you'll take away from this is some tips on speaking with people with some of these particular serious disorders. And so speaking with someone with dementia, it's really important to be focused on the feelings, not the words they're saying. But if somebody tells you, strange men are coming to my apartment, Think about how terrifying that must be if you feel that strange men are entering your home, rather than the reality that you believe this to be, that it's not really happening. You go ahead.
Yeah, so I just want to give another example. I'm sure many of you have heard complaints either from residents or from maintenance men that the maintenance man stole my wallet. And what you have to think about is how scary it would be, and for me it's not my wallet, it would be my phone. And I'm sure for many of you it would be your phone also. If you couldn't find your phone, you would be at a loss in so many areas: your phone, your camera, your banking, your calculator, your CVS card or your pharmacy card. All of those things are on your phone. So when somebody says, "You stole my wallet," or "Joe stole my wallet," think about the feelings that are behind that, and don't take anything personally.
All very hard to do, but very important. So you want to not argue. You want to try diversion or distraction. So an example of diversion or distraction, the woman who comes down and says, I don't know where my children are. They were due home from school hours ago. And obviously she's not waiting for her children, but you might try distracting and say, "Oh, I heard the school bus was a little bit late today. Why don't you come with me and see what we have in the library? We got some new books that I think you might find interesting, or come have a cup of tea with me and then we'll come out and look for the children." And that often is sufficient to move them along, and they'll have forgotten they were looking for the children by the time you've had the cup of tea or looked at the new books. Offer reassurance that they're safe and that you're going to make sure they stay that way. Next slide. Always reminisce rather than asking for them to remember. I think that's one of the hardest things that I've sometimes struggled with, when you say, "Oh, remember the good time we had at your 90th birthday party?" But no, yeah, they're not remembering. At your 90th birthday party, I loved how all your family was there and we sang and we danced, and it was such a wonderful time. Even if they don't recall it, when they see your joy and the pleasure you're getting out of it, they will experience that again too. As difficult as it can be, if you're asked the same question, "When is the bus coming?" continue to repeat the answer even if it's 10 times. You might try diverting them with something else to get them off of the topic, but don't say, "I've already answered that 10 times, I'm not answering it again." And remember, this is still an older adult who deserves our respect. Avoid talking down to them.
The thing that is important to remember around here is that a brain that is being affected by a disease, the folks don't want to be asking the same question over and over, and they don't know they are, obviously. So it's as hard as it is, we have to pretend that it's the first time they asked us.
And it can be difficult. Next slide. So these are some of the major dilemmas that we encounter when someone has a significant dementia. We have this commitment to people remaining independent and autonomous, but what about their safety and the potential risk to others? Starting a fire. We've all known of people who have put aluminum foil in the microwave and set off sparks and a fire, or turned on the stove and had papers on the stove, or left a pot on too long. And that affects, obviously, their safety, but also the safety and integrity of the building. Family dynamics. Unresolved issues get in the way of family helping to plan, and sometimes they refuse to recognize dementia symptoms and insist their parent is okay. How much can and should we get involved, and how? I recall in the last year having a situation with an elderly Chinese woman who had a very involved son and daughter, and they kept deferring to their mother as to making the decision, although the mother became increasingly incapable of doing that and had wandered away from the building and was brought back by the police several times. We were mandated reporters and had to get the elder at risk folks involved, protective services, and in a meeting with them, it became clear that they were so used to deferring to their mother that they really could not step up, and were relieved, actually, when the decision was made for them that the mother really needed to be in a protected environment, because being on the subways in downtown Boston at 2 in the morning was not a safe situation for this woman who was about 4'8" and maybe 80 pounds soaking wet. Then you get into a situation when the siblings have different takes on their parents' needs and they're in conflict. And what if there's no family involved or no family, period? So this becomes very complicated, and we have to look, and this is when the resident at the tenant at risk meeting is very helpful to sort of weigh all these things and think what the alternatives are. Next slide. So we're going to move away from the dementias now and speak specifically about depressive disorders. Very important, it is not a normal part of aging. And in fact, all the research indicates that overall, older adults generally report a better mood than middle-aged adults, who are the most at risk for depression. The common features of all types of depression is a sad, empty, or irritable mood, along with somatic and cognitive changes that impact the person's ability to function. What we know is that while 20 to 30% of older adults experience symptoms of depression, only 17% of them receive treatment, which is really very sad, because when people get treated for depression, 60 to 70% of them show a significant improvement. So it's really troubling that people are not getting the help they need that would really improve the quality of their lives. Next slide.
Can I jump in only to say that there's talk therapy and then there's medication, and both of those things should be considered when a person is having depressive behavior, and you might be in a position to recommend one or the other or both and have them talk to their doctors about it.
The most effective treatment for a significant depression is a combination of both medication and psychotherapy, and there's been a lot of evidence of CBT, cognitive behavioral therapy, being particularly effective with older adults. So here's a list of risk factors for depression. A few like tidbits that I think are interesting. If you had a parent who experienced depression, you are 27% more likely to develop depression. This is particularly a factor in those who develop it earlier in life. Women are 2 times as likely as men to demonstrate depression. Is this the role of hormones? Is it that they tend to have larger caregiving roles? Is it that they're more willing to acknowledge depression and therefore seek help? Unclear. It's really important to know, and I would hope you would be gathering this in your evaluation, to find out if there's a prior episode of a major depression. If so, they are 50% more likely to have an additional episode. And so having that information would let you intervene early on if you notice changes in their behavior. Certain illnesses, cancer, stroke, certain medications. All of these things can increase the likelihood of depression. A number of high blood pressure medications have been correlated with depressive symptoms. Then we know there's all the psychosocial risk factors. The big one we're all talking about these days is social isolation. Losses, financial stress, caregiving stress, cultural factors. Then we have the personality factors. If you have a history of being pessimistic, being rigid, lacking in self-confidence, those put you at greater risk. And then something that's really important when we're talking about elders who migrated to the U.S. They're often struggling with issues of trauma, a past history of PTSD, and they can be dealing with trying to acculturate to the U.S. while aging. That's a tough combination to deal with. There's the language issues and the cultural issues as well. People who've had a past history of domestic violence are at more risk. So we've talked a lot in the last time about cultural influences. Many people with a mental health condition, who are they going to turn to for help? In many cultures, clergy are the first source. So therefore, knowing who the culturally important clergy in your community, that's really a big thing to be thinking about. In some cultures, mental illness is viewed as a character flaw, and so they'll be very reluctant to reveal this. I was surprised to learn that in many Asian languages, there are no words for some common mental health disorders. So how do you talk about something if you don't have words to express it? So one of the questions that's in line with the cultural humility we discussed last time is, do you think your cultural background has a role in your feeling depressed? That might help you get to this. Next slide. So, list a bunch of the typical signs and symptoms of depression. And I know you're getting copies of the slides so you can review this at your leisure. But basically note that depression leads to an overall decrease in the quality of life. Next slide. There are a lot of these, and they really affect every aspect of what you might encounter. So it's a way of paying attention to this and noticing those changes. Next slide. So these are some of the factors that are affected and decrease the quality of life. There are decreases in adherence to medical treatment, recovery, their function, self-care, social relationships. We know that people who are depressed have an increased incidence of diabetic complications, a lowered adherence to medicine, exercise, and diet regimes. They recover less quickly. Nowadays, when someone's had a stroke, very often antidepressants are prescribed, and they have found that people who take antidepressants following a stroke have a much better recovery, regain more function. So that's really important. In terms of social relations, I just want to mention it's hard for both the person and those who live with somebody who's depressed. Someone who's living with a depressed individual are much more likely to become depressed themselves. So be thinking about that for your couples and siblings who are living together. Depressive symptoms including withdrawal, irritability, hopelessness, and helplessness are hard on relationships. Next slide. We also know that there's an increase in isolation, and there's been lots and lots of talk lately about social isolation as a risk factor for depression, but it can also be a consequence as people suffering from depression may withdraw from relationships and social activities. We know that home care patients, people who are pretty much homebound, are at risk of having very limited social contacts. And families, if they're involved, spouses, children, they may provide physical care, but not the necessary emotional support. Depressed people have much higher utilization of both doctors and emergency rooms, and they have an increase in rates of death by either suicide or from medical illness. This is independent of other variables. So, for example, following a stroke, those who are depressed are 3.5 times more likely to die within 10 years than non-depressed patients, which is another reason why they're prescribing antidepressants fairly routinely now.
And why, if you observe one of your residents exhibiting some of these behaviors, that you intervene for your, for their benefit, but for everybody's.
Next slide. So here's some tips for speaking with someone with depression. The biggest thing is to simply state that you know that something seems different about them and give a specific example to state. So, Mrs. Jones, I used to see you all the time at our monthly dance programs, and I haven't seen you there for a couple of months. I was concerned about you. What's going on? I have found it to be really powerful to state when you see depression, and especially if the person agrees to it, to state very clearly that you believe that no one should suffer needlessly and that depression can be treated, and that you're going to hang in with them and work with them to find the right treatment and the right person to provide that treatment, and that you're going to be staying involved until they're hooked up and feeling better.
So when we watch the role play, make note of what we did say, maybe what we didn't say, how you would say something similar, and let's take a look.
Thank you, Marcia and Karen. At this time, I want to remind everyone that for the videos, the sound will be coming from your computer speakers. So you want to be sure to turn up your computer speakers now. Your phone lines will be muted, but so that you can hear the video, please turn up your computer speakers.
So for coming down to see me today. I've been concerned because we've had several appointments that you've either not shown for or have canceled, and I've noticed that you don't attend any of the community events, and people tell me you used to be very active in the community here. You know, after Max died last year, I just don't feel like doing anything. I'm just not in the mood. I feel like if I did go to anything, I would just miss him that much more and be a downer for the other people. I'm sorry. It's clear that you're really struggling with this, and I know you told me when we initially met what a wonderful 55-year marriage you had, and it sounds like Max was a very special kind of guy. He was a great guy and a great husband. And it's hard to get over that, but you know, there's a difference between moving on and having some kind of a quality life for yourself while still honoring and remembering what you had with Max. Because I feel like I can't even go to anything and not miss the other half of me. Yeah, that's got to be really difficult. Have you had any help with trying to deal with this over the last year? Well, I talked to my friends, and some understand because some have lost husbands, and my daughter encouraged me to go see somebody. She found the name of somebody, and I went to see them, but honestly, we just didn't click, and so I stopped going, and I just don't feel like anybody can help because he's not going to come back. That's true. He's not going to come back, but I do believe, and I have seen it, that with the right kind of help and maybe a little medication, that you can have a better quality of life for yourself and for your surviving family members while still honoring Max's memory. So I wonder if you would allow me to try to help to find you somebody who might be a better fit that you can talk to and get some support. And who takes my insurance? Will take your insurance, and all of that I know is very important, and I'll be there to make sure that we find the right fit, because I do believe that you can have things be a little more comfortable for you, and that will be good also for your daughter and your grandchildren, for you to be able to find a way to get some pleasure in your remaining years. So can we agree to sort of work on this together? I suppose. We'll see if it works. I would be willing to see if it would work. Okay, well, I'm going to hang on to the hope that things will get better for you. And we'll meet again, and I will give you a call when I have an idea of who might be a good fit, who takes your insurance, and that you can get to see them. Okay. Thank you. Thank you.
All right. So take a deep breath, and we're going to race through a little bit about anxiety disorders. Karen and I are suddenly aware of the time clicking on us. Anxiety disorders are really common. Up to 40% of people with chronic medical conditions also have some symptoms of anxiety, and people with dementia also are very likely to have some symptoms of anxiety, with over 20% of them having a diagnosable anxiety disorder. There's a lot of overlap between depression and anxiety. About half of people who have a major depression also experience significant anxiety, and about a quarter of those with an anxiety disorder also have depressive symptoms. So it's hard to tease out. Next slide. These are some of the common physical symptoms that we can all identify to feeling when we're nervous. It's the degree and how common and how they interfere. A lot of times older people speak about chest pain, difficulty breathing, weakness, and pain, and a lot of visits to doctors or emergency rooms are really due to anxiety rather than to a condition like a heart problem. Next slide. The behavioral symptoms are ones that can be more easily missed, and especially that requires you paying more close attention and finding out a lot about people. The difficulty making decisions is something that resident service coordinators often know. That can be the person who's coming because they don't know whether a letter they got in the mail requires them to respond. They're the folks I mentioned the last time who are down in your office each time Medicare sends out, "This is not a bill," one of those statements saying, "Are you sure I don't have to pay anything to this?" That's a tip-off that this may be somebody with anxiety. Next slide. Lots of signs and symptoms. So these are the feelings that people who are experiencing a lot of anxiety have. And next one is about the thoughts they might have. And each anxiety disorder, and there are a lot of them, has different symptoms, but all the symptoms cluster around having excessive and irrational fear and dread. You know, if there's a terrible hurricane warning that I hope none of you have recently been affected by that live in those areas, and you're feeling very anxious because they keep talking about the hurricane approaching and you're struggling with making preparations or evacuating, having anxiety is normal. That's not irrational. So that's the thing to keep in mind. Getting on an airplane and thinking the plane is going to crash is irrational because most times the plane doesn't crash. So anxiety becomes a mental health problem when it occurs frequently and with high intensity, and/or it interferes with the older adult's ability to function and manage everyday activities. So this is occurring when there's no real threat or danger. So just a quick note about hoarding disorder, because that's such a problematic issue in senior housing. It's a separate diagnostic category at this point, and it's often seen in older adults, and it takes up so much time. What's important to note is that approximately 75% of people who have a hoarding disorder also have a depressive or anxiety disorder. So I know you're going to have some specific training on hoarding if you haven't already, but be aware that depression and anxiety also needs to be addressed. Next slide. So here are some tips for working with a person with anxiety. These are things to be sort of looking at and working with them on these issues. Treatment often consists of medication and talk therapy with, again, cognitive behavioral CBT therapy, and problem-solving therapy approaches are often very effective. So as Karen mentioned, getting the names of people in your community who, A, accept your residents' insurances, are either available for home visits or their office is one that people can get to, and knowing what their approach is and that they're comfortable and like working with older people, establishing relationships with them before you need to make a referral makes a huge difference.
And again, you'll find that form on the website at the back of the, or as an attachment to the guide.
Providing education and support is something that IWISH staff can certainly do. There are structured ways to manage anxiety, such as progressive muscle relaxation, sleep hygiene, deep breathing. It's working with their primary care about medications. They have to be used very carefully. There's a lot of problems with older people and medications used for anxiety. You want people to use them for the shortest time possible and in limited amounts. Next slide. So this is a difficult topic to discuss, but it's really crucial. I don't know how many of you have worked in housing for any time, but when I've spoken at conferences and asked how many have experienced or suspected a suicide occurring in their buildings, I've been astonished by how many hands have gone up. I've personally supported staff in some buildings where this has happened, and it is very traumatic, not only for the staff, but for the other residents. What's important is that although the U.S. highest suicide rate was amongst adults between 45 and 54 years of age, the second highest rate was in those 85 or older, especially among men of all races. Men over 65 were the most likely to commit suicide, and they accounted for 7 of 10 suicides in 2016. It's really difficult to discuss, but important to know and to understand. The risk factors are the same as for depression, but also if they've had prior attempts. So that's an important thing to ask when you're doing an evaluation and find out there's a history of depression. Asking if they've ever attempted to hurt themselves or to die by suicide. A sense of hopelessness and, crucial, access to lethal means. The most common ways that people die by suicide in this country are guns and hanging, followed by medications. And so we know that the elderly often have access to a lot of medications. I'm sure that in all of your buildings, weapons, guns are not permitted. That does not mean there aren't any in your buildings or they don't have access, particularly people who were hunters or were in the police or sometimes in the military. It's worth asking the questions about it. You'd be amazed at how often people will tell you. And then you can see about having them removed. Hanging is another factor, and there's always lots of ways of going about that. So we've reviewed a lot of the risk factors. Let me just talk about some warning signs. Talking a lot about death, being that people would be better off without them, the family, they're not needed anymore. Really withdrawing, a lack of interest in things, a sense of feeling like they're a burden, putting their affairs in order, giving away prized possessions, and increased substance use that we're going to talk about in a moment, rage. A sudden mood change. If they're depressed and then they feel better with meds, they're at higher risk at that point because they have the energy then to develop a plan and carry it out. With older adults, you might see them taking risks, unsafe driving, gambling, giving away money, refusing treatment, somebody stopping kidney dialysis. Is that a realistic decision, or is that a passive form of suicide? Refusing food and drink. It's not uncommon that that's a way of going. Very important to know, in older adults, actually reporting suicide is underreported by as much as 40%. So why is that? There's assumptions. They died in their sleep. They died of old age. It's very hard to know if somebody didn't leave a note, and older people are less likely to leave a note. They're not going to do an autopsy on a 90-year-old who had a documented history of heart disease. They're going to assume they died in their sleep. So there are a lot more suicides amongst older adults than we know about. Also, another thing to keep in mind is that 1 in 4 older adults who make an attempt actually die by suicide as compared to 1 in 100 of younger adults. So why is that? Well, first of all, they tend to use more lethal means. They're often more frail. So even if they're found, they don't recover as easily from an attempt, and they often live alone, so they're not found in time. Next. So in older adults, there are a lot of cultural considerations related to this. The highest rates of suicide are in Caucasians, followed by the American Indian and Native Alaskan groups. There are some cultural and religious beliefs that discourage suicide and support instincts for self-preservation, and these are often found in the African American and Hispanic communities. In some cultures, depression and anxiety are often expressed as physical complaints. Latino residents may speak about anxiety and stress as a brain ache or being ill with nerves. The one factor that I was surprised to learn about, but that makes a lot of sense, is Asian American women in the 65 to 85 age group had the highest rate of suicide for all groups of females in this country. And experts attribute this to changes in their cultural and social roles in the United States. They feel useless when not able to fill the caretaker role anymore. So there's a lot of stigma that can go along with this. Language can be a major barrier to getting appropriate mental health providers. It can also hinder the person's ability to trust those providers. effectively communicate their concerns, and advocate for themselves. Groups who come from other countries with a history of trauma and persecution, they can really suffer from PTSD, which can lead to suicidal feelings. So there are a lot of barriers to treatment. It's hard enough being an older person, being dependent on insurance, having trouble with traveling to a therapist. When you add in language, fears related to immigration status and stigma, it becomes very challenging to get the care people need. Next slide.
Let's take a look at an example of a role play.
Thank you, Marcia and Karen. Again, as a reminder, please turn up the sound on your computer speakers now, so that way you can hear the video.
Hi. So thank you, Mrs. Jones, for coming down to see me. When I saw you in the mailroom yesterday, I noticed how depressed you seem. Oh, yeah. What's going on? So, you know my daughters, right? So the one who has the kids, she's moving. She's going to move to a whole other state, like far away. Oh, my goodness. That's very unsettling for you. All right, take a deep breath. I can see that this really has you. It's on my mind all the time because she was the one who I counted on for everything. She took me to doctor's appointments. Sometimes she made the doctor's appointments. And she would pick up my prescriptions for me, and she would fill my med box for me, and I don't know who's going to do all that stuff now. Okay. So there's really a lot you're concerned about right now. Well, wouldn't anybody be? Absolutely. So, first of all, can I get you a drink of water? Okay. Oh, thank you. So let's take a deep breath, both of us. Okay, let's catch our breath, and let's talk about this. So, this is Joni, right? Yeah. Okay. And Joni lived right near you, and you really was your rock. Oh, yeah. She does everything for me, and she's my oldest. So, we've just had this wonderful relationship, and I can't believe that, that why is she leaving? Well, because her husband got a job in another state, and it was a really good job, and I'm happy for them. I really am. But I don't know what I'm going to do. Okay. So let's sort of break this down into what are the pieces of it. So some of the things that you're anxious about, like filling your med box and helping with some of that. Yeah, who's going to do that? Okay. We can talk about that. And maybe we have a nurse connected to this program that I think she may be able to help. I met with her. She's very nice. Okay, so maybe we can talk with her about Will she fill my med box? That's a good question. I think we have to ask her, and if she can't, we can find somebody that we can arrange to get this done. That's a really important thing. Okay. Before she started filling it for me, I was a little mixed up about it, and I did some stuff wrong, and actually once I ended up in the hospital because I took 2 days worth of pills in one day, and anyway. Yeah. I hear how stressed you are about this, and so let's talk with the nurse. We're going to do that and see about getting the pill issue straightened out, and we'll also talk about some of these other issues. But I am concerned about the toll this is taking on you. How are you sleeping? Good one. I'm not sleeping. I'm not so much sleeping. I'm exhausted by 8 o'clock at night. I fall asleep in the living room, and by midnight I'm awake, and I'm awake. So it seems like I'm awake for the rest of the night. And this has gotten much worse since Joni told you she was moving? Yes. Yeah. Okay. So I'm wondering if it would be okay when we speak with the nurse. I think we should also see about speaking to your primary care physician, and it might be helpful, at least for the short term, till things settle down, to get some medication to help with your anxiety, because this is really interfering with your functioning if you're not sleeping well,
and you're clearly very, very anxious, and it must be pretty uncomfortable for you.
You know what? I guess so. I didn't even think of it until I realized that I'm like nervous all the time.
What a horrible feeling that is.
It is.
Okay, so our next step is let's speak with the nurse and let's see what our next things can be. And after I think she speaks with you, maybe the two of you can have a conversation with your primary care.
Yeah, I think that's a good idea because there are so many things that could go wrong. I just don't know how I'm going to handle it.
Okay. Well, we're going to come up with a plan to try to help because this is a lot, and I'm sorry you're having to deal with this now. And even without dealing with the practical issues, you're going to really miss Joni and the kids. I know you look forward to your Sunday dinners with them at their house, and it's going to be a real change for you.
It is. It really is.
So we're gonna work on this. So you and I are going to meet again, and we're going to get the nurse involved too to help on this. Okay?
I feel lucky to have you guys in my life, even if you can't do what Joni is doing for me.
Well, we're glad to be here for you.
All right.
Okay, we'll speak soon.
Thank you.
Bye-bye.
Okay. Let's all take a deep breath for ourselves as coming down. Sitting with Karen in that video made me anxious.
And I was anxious for like 15 or 20 minutes after the recording of that.
All right, switching to substance use disorders, I think it's really important that we look at this because it does affect up to 17% of all older adults, with the biggest problem being with alcohol. A substance use disorder consists of cognitive, behavioral, and physiological symptoms indicating a person continues using a substance despite significant problems related to it. In the U.S., among all age groups, alcohol is still the most used and abused substance. Even though older adults currently use less alcohol and illicit drugs than younger folks, this is starting to change due to the baby boomers. Many of these younger adults younger elders who are starting to fill our housing sites have used alcohol and illicit substances such as marijuana, and they're expected to continue doing so as they age. The rates of illicit drug use is climbing. Currently, non-medical use of prescription-type drugs is more common still than even marijuana use among those over age 65. Often, older adults misuse anti-anxiety medication, sleeping pills, and pain medications. While alcohol or prescription drug misuse are most likely to present to you, be aware that increasingly residents may be using marijuana or other drugs that may be in violation of their lease, even if they're legal in the U.S. You are not permitted to report anything they share with you under the IWISH program to property management, but you might want to assist them in addressing pain or other issues that are getting them to use these substances. You need to be clear that you wish to help them get treatment, but that their tenancy may be at risk if they continue to engage in behavior that's in violation of their lease. A good question to ask is, do you like living here? Where would you go if you were evicted because of your drug use? I have found that to be a very effective way of getting people to be more open to considering alternatives. Next slide. Okay, prescription drug misuse is certainly problematic. The risk of misuse goes up with being female, socially isolated, depressed, and if there's a history of substance misuse. Widows and widowers sometimes start using the meds that were left behind when the spouse died. There can be serious health consequences because of the difficulty in metabolizing meds with age, drug interactions, but we also want to make sure that older adults are adequately treated for their anxiety, their pain, and their insomnia. It's difficult to screen because elders will often deny misuse, and doctors under-recognize and under-report substance use disorders in older adults. They often mistake these symptoms as symptoms of dementia or depression. Next slide. I want to spend a minute or two on alcohol use disorder, given that that's the biggest problem. A large number of people have used alcohol throughout their lives and are continuing to do this. Even low levels of drinking can cause significant problems for older adults. Females are more vulnerable to some of the physical consequences, such as liver disease. At least 10% of community-dwelling elders are likely impacted by their drinking, and it can affect the whole housing community. If you've ever had someone, and I've seen this, who is intoxicated and comes into a community event, it can stir up lots and lots of problems.
And it makes the other residents feel uncomfortable.
So this alcohol use and medication interaction is a common problem. Next slide. There are interventions that, such as motivational interviewing, which I believe you've had some training on, that can be helpful, and cognitive behavioral therapy also can be helpful with this. When you're working with somebody with a substance use disorder, it's very important to start from a caring place. If they're inappropriate in a common area, help them to leave the common area, both to save them embarrassment as well as to avoid a disturbance, and let them know you'll speak to them later when they're not intoxicated. Next slide. I want to emphasize that it's a medical emergency if the person is very disoriented or unresponsive, and you want to focus on their well-being and their future tenancy. Next slide. Just to acknowledge that suicide is a leading cause of death amongst people of all ages who misuse alcohol and drugs, and overdoses often involve multiple drugs. Next slide. Sort of to wind up this rushed end of the presentation is I want to mention the QPR strategy that people can look up about, but basically when you are concerned about someone who's potentially suicidal, this is an intervention anyone can use. You talk to the resident and be direct. The question, are you having thoughts of suicide? Persuade, I'm concerned about you. Do active listening and refer. I'd like to help you, and then help them to get connected to someone else. If you're not comfortable, ask somebody else to assist.
Use your resources.
Next slide. So you can save a life. Our work in creating supportive housing communities that combat social isolation and help provide meaning and purpose in the lives of older adults is crucial in preventing suicide.
So that brings us to the end of a very rushed. Sorry about that. We had a lot of information to share with you.